Okay.
Just have to click got it.
Okay. So thank you, Dr. Berinstein, for coming this evening. And in some ways, he's not a stranger to us. We've had him before, and we're very grateful that he's agreed to speak to us tonight. He's the professor of medicine and immunology at the University of Toronto. He's certified in internal medicine and medical oncology in Canada and the USA. He's held multiple leadership positions over the year, including vice president, Sanofi Pasteur Cancer Vaccines. I don't know if I pronounced that right. Vice president of the Ludwig Institute of Cancer Vaccine Consortium and director of translational research at the Ontario Institute for Cancer Research. He's active in clinical and translational research in the areas of lymphoproliferative disorders, myeloma, and cancer immunotherapy. His clinical practice is focused in the management of patients with lymphoid malignancies and myeloma at the Odette Sunnybrook Cancer Center. His research interests include integrating and evaluating novel biologic-based therapies into the standard treatments for cancer, and in particular, non-Hodgkin's lymphoma. His research includes using novel biologic assays to document the immune status of patients, predict response to therapy, and to document immune activation systemically and in the tumor microenvironment. He's the lead principal investigator on several multi-center clinical trials involving diseases such as recurrent and refractory diffuse large B-cell lymphoma, Waldenstrom's, macroglobulinemia, and COVID-19 protection in patients with CLL. He's committed to advancing new biological therapies for patients with cancer. So welcome, Dr. Berinstein.
Well, thank you very much for inviting me. I always enjoy coming and talking about some of these things that I spend a lot of time professionally working on. So it's, and I know what I'm working on is of interest to many of you. And Betty invited me a while ago to provide an update on our trial, which I know I've spoken to you about previously, about a year ago, and the BRAWM trial. So I am going to do that. And then she also said, well, why don't you also say a few words about COVID and COVID vaccination in patients with immune suppressed diseases such as Waldenstrom's. And so I'm going to do that as well. So that's the plan for this evening. It's not a long presentation. I've left plenty of time for a discussion. And I hope that there'll be some questions, and I don't mind being stopped at any point for clarification, or if I say things that don't make sense or you'd like me to clarify, feel free to. Now you should see my screen. Do you see a slide now?
Mm-hmm.
Okay. So you should, yeah, show you.
BRAWM on the bottom.
Yeah, very good. So, okay, very good. So it looks like it's working. And
I'll just remind everyone to go on mute. And I think we're good. Sorry, go ahead.
So BRAWM is the name of the clinical trial that I'm going to talk to you a little bit about. And BRAWM stands for Benadmustine Rituximab Acalabrutinib in Waldenstrom's macroglobulinemia. And this is a phase 2 trial looking at the integration of this new second generation BTK inhibitor, acalabrutinib, in previously untreated Waldenstrom's macroglobulinemia in combination with Benadmustine Rituximab. So the thinking behind this trial is that, yes, we have some very, I mean, Waldenstrom's is an indolent type of lymphoma, as many of you know. And people who have Waldenstrom's can go on for many years without requiring treatment, but often, for most patients, at some time, they will need treatment. And there are many different treatments that can be used. And if you go to different parts of the world, if you look at different parts of the world, I mean, the US, Europe, their first-line treatments for Waldenstrom's are different than all across the globe. And it's not clear what therapy, first of all, is the best, will be most effective, will induce the longest responses, and which ones will also be non-toxic and able for people to tolerate. So one observation, though, is that with all of these treatments, patients do eventually have their Waldenstrom's come back. These are not curative treatments. And if you actually look at the responses that are generated from most of the treatments that we have available now, whether it be Benadmustine and Rituximab, which has been the standard of care actually in Canada, I would say. If you look at the response rate and the complete response rate, there's very few complete responses. Even in places where they use ibrutinib or a BTK inhibitor as first-line therapy, if you give monotherapy ibrutinib or ibrutinib with rituximab, there are very few complete responses. Most people will experience a partial response, which is fine. I mean, usually these partial responses are associated with improvement in symptoms, and if people were anemic before, their anemia will improve, and most of their symptoms will improve. So it is a meaningful partial response, but it does tell us that there is room for improvement in the responses. There's room to have deeper responses. In some other types of lymphomas, for example, diffuse large B-cell lymphoma, the first-line treatment that we use for diffuse large B-cell lymphoma induces 70% complete responses. In Waldenstrom's, the first-line treatments that we have, the complete responses are closer to 3% or 5%, and most of them are what we call either very good partial responses or partial responses. And where you do obtain complete responses, for example, in diffuse large B-cell lymphoma, there is a cure rate. And that's not the case with Waldenstrom's. We know that in most situations, almost all situations, Waldenstrom's will eventually come back many years after the initial treatment, but it will come back. So the idea here was, well, can we generate deeper responses? Can we generate complete responses, a higher frequency of complete responses, or at least a higher frequency of what we call complete responses and very good partial responses, which is very close to a complete response. And so the strategy to do this is to combine the first-line treatments that are used in different parts of the world. So in Canada, we use Benadmustine and Rituximab as our first-line treatment. But in many places in the United States, for example, they use a BTK inhibitor. They use ibrutinib. And these are both very effective, and they both induce these responses and durable responses, but not high frequency of complete responses. So what we've hypothesized here is that perhaps if we combine Benadmustine and Rituximab with a second generation BTK inhibitor, we were fortunate enough to be able to acquire Acalabrutinib, perhaps we will get a higher frequency of complete responses and maybe even what we call MRD negative states, either in the bone marrow or peripheral blood, and that this would be associated with even longer durations of response. So that's the idea behind this trial. Waldenstrom's, as you know, is not a very common disease. There might be 100 or 150 new cases each year in Canada. So that's relatively small with respect to different cancers. Although there are a lot of patients, the prevalence, meaning the number of patients who have Waldenstrom's, is much higher because many patients either don't need treatment, live a long time. And so the number of patients who have Waldenstrom's who may at some point need treatment is even higher than that small sort of number that occur every year. So that's the idea. That's the hypothesis that we could increase the complete response rate by combining those two treatments. There is one trial that looked at that approach in CLL, and what they showed was that yes, there is a deeper, or there are longer responses, more durable responses, and they also showed that the toxicity profile from the treatment wasn't made significantly worse. In fact, they said it was acceptable and what you would expect from combining those two treatments. And that's important because when you combine drugs that have the same mechanism of action, you might expect there to be enhancement and very severe toxicities. But these are two different. These treatments work in different mechanisms of action, and that's why we felt that the toxicity profile shouldn't be accentuated. So that's the trial, and the primary objective of this trial is to document the best complete and VGPR, so it's almost a complete response rate of first-line treatment with bendamustine rituximab plus acalabrutinib in patients with Waldenstrom's macroglobulinemia undergoing their first treatment for Waldenstrom. So we will not use this for patients who've already had previous treatment. It's only for first line. And then there are a number of secondary objectives, which are to document the overall response rate, minimal residual disease rates, and that's an exciting part of this trial because we are going to be sending these samples to a lab in the US. That's actually an expert lab in doing what we call next generation sequencing, minimal residual disease state. So they're going to be able to detect Waldenstrom's in a bone marrow peripheral blood specimen at 100,000 times greater level of sensitivity than any current clinical test that we have. So they'll be doing that at multiple time points in the study, and also to look at the overall survival of patients undergoing this treatment, the progression-free survival, the safety profile, and the time to the next treatment. So this is, I don't know how well you can see this on your computer. I've taken just one document or one, it's called the schedule of events. There's several pages of this, but this just shows the design of the study. So bendamustine is given every month for 6 months on day 1 and day 2. Rituximab is given on day 1 of every month, and acalabrutinib is started on day 1. It's given twice a day continuously for 1 year, and then it stopped. And before in the screening, people will undergo CT scans, they'll undergo bone marrow tests, other blood work, history and physical exams, and then they'll have assessments every month, and then every 3 months, and then there'll be what we call extended follow-up. That's the design of the trial. And this trial has been open for pretty well over a year, and it's a very labor-intensive process to start a clinical trial because there's documents that have to be created, contracts that have to be created, legal contracts. There's Health Canada approvals that need to be obtained, IRB approvals that have to be obtained, research contracts with different sites. We have to identify different sites that would be willing to participate with us, and then get them activated and teach them about the protocol, et cetera, et cetera. So basically today's update is to tell you where we are with this trial. And we've had one amendment of the protocol. So it's not unusual for when you start a new clinical trial to, after you've treated a few patients, to realize there's a few things in the protocol that have to be fine-tuned. In fact, I've never been associated with a protocol that where this hasn't been the case, and sometimes you even have to do 3 or 4 amendments. And so we've already filed the first amendment, a few just different details in terms of cutoff values for labs that will accept, and just minor things, but they still have to, if we're going to change them in the protocol, we have to let Health Canada know, we have to let the internal review boards of all the sites know. So that's been done for one amendment with a number of, and one thing we also had to incorporate in the amendment was that there were some modifications to what we call the investigator brochure. So the acalabrutinib is coming from AstraZeneca, and AstraZeneca is doing other trials around the world with this drug. And as they get in new data, they have to modify what they call the investigator brochure. Then that gets sent to all the different trials. And then we have to incorporate that into our protocol. And usually it's just some update on some of the side effects that they see, and really nothing major, but it is something that has to be done and submitted to both our ethics and the Health Canada. So that amendment has been done. We've enrolled now 6 sites. We have 10 that we think will be enrolled. Accrual period is expected to be 2 years from June 2021 to June 2023. This month, we've initiated 2 additional sites, and we've had 1 newsletter that's gone out to our investigator. So I want to show you the sites that we have. These are the sites that are up and running. We have Sunnybrook and the status of the site. So Sunnybrook, we've actually entered 3 patients in this trial, and there's one more who actually, I believe this one in screening has now been entered on the trial. BC Cancer Agency, they took them a little longer to activate than we had hoped, but they now have 2 active patients. We have Halifax, so we actually go from coast to coast, which is kind of a nice thing to see. Dr. Forward, he's already has 1 patient, and he's had 1 patient who's been a screen fail. So when we enter patients into a trial, patients have to meet certain inclusion and exclusion criteria. And 1 patient was screened, was felt that this patient might be eligible, but when we did all the detailed screening, and for one reason he was ineligible. We have Ottawa, and they have 3 patients that have been already initiated on the trial. We have a site in Quebec, and that site is just starting, and we have a site in Calgary, and that site is just starting. And then we have a few other sites that actually, here's additional sites that are not yet open. We don't think all of these sites will eventually end up being involved in the trial, but most of them will. So we will have over 10 sites accruing patients. And this shows, again, what I've sort of, this is a summary of what I've just told you. We often screen more patients than we end up entering. And so there's been 12 patients screened, 10 patients have been enrolled. 1 patient's had to come off the trial because of some toxicities. There was, some toxicities which were, which the physician and patient decided to stop the trial. This shows how we want to acquire 60 patients in the study, this shows you the anticipated enrollment. This is expected recruitment when we first put the study together. This basically assumed that we had started a little earlier and that we had more sites activated earlier. It's taken us a little longer. But given what we know now, this is what we expect, and this is where we are. So we are on track to have 60 patients enrolled by June 2023. So we are pleased with that. There will be follow-up. So it doesn't mean the study is over then. It just means that we won't be entering new patients at that time point. We have had a few other sort of, I guess we call them events. One is or other events that are somehow related to this. One is our relationship with Waldenstrom's is Foundation of Canada. We are very pleased with that. And we know that the Waldenstrom's Foundation of Canada has sponsored Dr. Treon, and Dr. Treon gave a very nice talk a few weeks ago. And that was, I think that's a strong, our relationship with the Waldenstrom's Foundation is very important, both because of educational events like that, but also because I know that there's good communication amongst the members and information, and it's a place where patients can get information on trials like this. I'm talking here tonight. We've put that down. We've also another event that has happened with this trial is that there's one of another hematologist in Toronto, Dr. Sidney Chow, is very interested in acquiring some of the samples. We will be taking a lot of samples at multiple time points on these patients. I mean, just 60 patients, and you can bone marrows and peripheral blood. There's quite a few samples that will be valuable samples that will be stored, and we will use these samples for various purposes. But Dr. Chow would like to do a more detailed analysis of the molecular events that may occur in these patients. In other words, the mutations. So we know of certain mutations that are a feature of Waldenström, such as MYD88 and CXCR4 and P53, and there's a few others. But she has, along with some colleagues at Princess Margaret, developed a panel of 27 genes, which she can basically sequence. And these are genes that she's identified as being important in other lymphoproliferative disorders and causing in sort of pathologically being important. And there's reason to believe that they have been identified in some individual Waldenstrom's patients. And she's proposing to basically acquire the samples from these patients that we are collecting and doing this type of analysis. Now, this is not simple in many aspects. One is she needs to get funding for this. She's working on that. I think that she's, in addition, we have already in the amendment, just anticipating that this would happen, we have amended the protocol to indicate that these are samples that would be, that they are optional samples that the patient would have to agree. And there will be an optional consent. So far, we haven't collected these samples on the first 10 patients. It will be possible to go back retroactively and get patients' permission to use samples that are stored that we are using for other purposes. So that's something which I think could be very exciting, to identify other genes, perhaps like MYD88, that are associated, and perhaps predict which patients are going to respond better to this treatment that we're giving, or conversely, which predict who are not good candidates for this treatment. So I mentioned that we're doing these MRD tests, and these are being done in the peripheral blood and bone marrow. They're all being collected, and they have been collected religiously. They are being stored at the sites, and our agreement with the company called Adaptive, the research lab, was that when we acquired the first 20 samples, and we are very close to having 20 samples now, that we would send the first batch and they would run the first set of samples to look and see if they can detect MRD in bone marrow and peripheral blood of these patients. And this will be done at multiple time points. And we are right now starting to think of meetings that we could present some of the data, because shortly we will have some data on a number of these patients. And it's not going to be end data or final data, but it could be, it will be of interest again to promote the trial and get feedback. And this is often what's done with trials in progress. So that's another event that's taking place. And so that's a summary of where we are with this trial. And this would be a good place to perhaps stop, because the next, I'm going to move on to talking a little bit about a vaccination in Waldenstrom's, and actually vaccination in B-cell lymphomas in general. So if there are any questions or comments or clarifications, I'm happy to answer those comments now.
I should know this, but what is MRD?
MRD means minimal residual disease. So generally, in order to judge how well a treatment's working, we do x-rays or we do blood. We look at the IgM level in patients with Waldenstrom's, so that's a blood test, and that gives us an idea of, is the amount of the Waldenstrom's decreasing or is it increasing? And those are the clinical tests that we use. But MRD is a research test, which so when the IgM goes to a normal level, and when the x-rays show no evidence of splenomegaly or lymphadenopathy, which we hope will happen in many patients, the MRD can still show us this very low levels of Waldenstrom's in either the bone marrow or peripheral blood. And as I mentioned before, it's 100,000 times more sensitive than any other test we have. So when the CT scans are negative, the IgM is negative, we could still see MRD. And we want to see how low we can get this level. Can we make it, can we even cause complete responses when we look at this MRD test? Can we make that go away completely? And so that's what MRD is.
Thank you.
Now, in some diseases, MRD is used to decide when to stop treatment or to alter treatments in some leukemias, but not in Waldenstrom's. But that could theoretically be an outcome, in that if we were to see, let's say, at 6 or 9 months, patients become MRD negative, one might say, well, do we have to continue the acalabrutinib? Or let's say we see that it's still persisting after a year of treatment. Maybe they need more acalabrutinib or longer duration of acalabrutinib or ibrutinib or whatever the treatment is. So, so that's how eventually down the road this test could be used. I see a hand up, I think.
Dr. Berinstein, the candidates for your clinical trial are people who have been determined to be in need of immediate treatment as opposed to somebody who's on watch and wait?
Yeah. So it wouldn't be fair if we were to, yes. So we don't, it's really not ethical to start a treatment before patients need it. So, and your results would be, of course, better if you did that. But we want to be able to compare these results to other trials and other treatments, and generally the convention is that there are certain criteria that are used to initiate treatment, and we are following those guidelines. And those guidelines have been created by the International Waldenstrom Foundation, Waldenstrom's Macroglobulinemia Working Group.
So Dr. Berinstein, if you get a patient that needs treatment, this is suggested to them. Do many reject? Like, what's the ratio? What happens when someone says, okay, you're ready for treatment? Do you offer this to them?
Yeah. So I think almost everyone is enthusiastic about this trial. And some people are coming here are coming, or we've heard about it specifically for this trial. Now, do I enter every patient on this trial?
Yeah.
And the answer is no, because I do have some people in their 80s who, I have one lady, I think 85 or whatever, who has become increasingly anemic and requiring transfusions, and as her Waldenstrom's is progressing, and I need the most gentle treatment I can for her. And I didn't think that this would be a good treatment for her. So there are patients who are not good candidates for this, and we don't necessarily enter everyone, but anyone who's untreated, most patients are enthusiastic. I haven't had anyone turn us down yet.
Yeah. So if you're waiting till 2023 to get more people into the trial, it'll be a few years after that before the trial concludes and you get all your conclusions, right?
Yeah. So what I said is that by June 2023, all 60 patients should have been entered into the trial. But then there's follow-up, and each patient is followed pretty well for a year.
Okay.
And so the formal end of the trial would be 1 year after that last patient is entered. So it would be 2024.
Okay.
And then there would still be extended follow-up, but we would be able to basically close the database and look at the results and basically issue a final report after June 2024.
Thank you.
So if somebody is on watch and wait right now, but before June of 23, it was found that they needed to be treated, then they could be a candidate.
Definitely.
Okay. And you will have a site, or do have a site, in Edmonton?
Yes, that site will be up and running very shortly.
Okay, thank you.
I was just, I don't know, can you hear me?
Yes.
Yep.
I was just curious to ask, the patients that you have in the trial right now, are they all at mid-88 mutated or not? Do you have some who do not have the mutation and some who do?
They all have mid-88. The literature says that 95% of patients with Waldenstrom's are mid-88 positive, mutated.
So I can assume right now that for those who don't have the mutation, they wouldn't respond to Acalabrutinib. Is that correct?
No, some other low-grade lymphomas can respond to it, but the other thing is that depending on how long ago that was assessed in the patient, if a patient's gone 5 years and they were MID88 negative 5 years ago, and now they're requiring treatment, I would suggest that it be done again. And it could be that clones have developed that are mutated. So that's what I would do in that situation. But it's not a first-line treatment. I mean, obviously, if you have this mutation, you're going to respond better. But let me also tell you about the situation with CLL, chronic lymphocytic leukemia. That doesn't have MID88 mutations, but there is activation of that signaling pathway through other mechanisms, and BTK inhibitors are a very important treatment in CLL. just as important as they are in Waldenstrom's. So, the mutation doesn't, presence or absence of the mutation doesn't mean you won't respond. Yeah.
Did you-
But initially, people were telling us that if you didn't have the mutation, you wouldn't respond to ibrutinib or acalabrutinib. So
Yeah.
there's different opinions right now, as far as I can understand from what you're saying.
Yeah, so as I said, it's not a first-line treatment for a non-Hodgkin's lymphoma that doesn't have MYD88. For example, many marginal zone lymphomas look like Waldenstrom's, and they are MYD88 negative. And I wouldn't treat those patients with ibrutinib because we know it doesn't work as well. Whether it works, it may work, but not nearly as well as it will in CLL or in Waldenstrom's. So I'm not sure I'm disagreeing. I'm just I'm just being a little less didactic about how I see that. Yeah.
Thank you.
You said you looked at mid-88. Did you also check for the CXCR4 mutation, the other mutation at all?
Yeah, so that's one of the advantages of being on this trial. There are many advantages of being on this trial. And of course I'm biased, so but one of the advantages is that we will do at the start, at entry of the trial, the screening period, we will do MYD88, we'll repeat it even if you've had it before, we'll do CXCR4, and we'll also do P53 analysis. So those are things that are not routinely, the last two are not routinely done on patients. I don't know how many of you have had those done, but it's difficult to get those done in most places. I mean, we did a poll of this across, when we were screening for centers across Canada. We asked how many centers, everyone does MYD88, every center, but very few do CXCR4. And so we wanted to know, could we get it done locally? But it turned out we couldn't, so we have a central lab that's doing it.
Okay.
Dr. Berinstein, if you are enrolled in this trial, does the patient find out themselves if they have mid-88 or CXCR4? Do they get that information?
They can get that information. Yes, it's not done immediately, but we are getting that information. This is not what we call a blinded trial. It's a single arm trial. Patients know what's happening with their IgM at every time point. They get a lot of information. They know what's happening with any imaging they have. They know what's happening with their bone marrow tests. And as we get these results, there's no reason why we wouldn't share them with the patient.
Dr. Berinstein?
Yep.
Yes. As a treatment naive patient, myself imminently starting on zanubrutinib, this study would be something that perhaps my doctor could refer me?
Definitely. Where do you live?
Oh, I'm a patient at Sunnybrook.
I'm surprised it hasn't been mentioned to you already.
It hasn't been.
That's shocking. Well, you should definitely inquire about it. I don't know, and this is not really the time to go into your clinical situation. I don't know the details of yourself, your medical history, and things like that. I mean, there could be reasons why it hasn't been, other medical reasons or contraindication. I don't know, but the point is that most patients would be someone who should be considered for this trial, and I'm surprised. I mean, Sunnybrook, everyone at Sunnybrook, all of the other hematologists know about the study, so I'm surprised that they haven't mentioned it to you.
Someone in the chat has typed in, why do hematologists in Halifax not check for mutation? The doctor says it doesn't make a difference for treatments, although I always hear specialists say it does. How does this person get help?
No, I mean, it's like all prognostic factors. For every type of cancer, at the time that a patient is starting a treatment or a new treatment, there are prognostic parameters that have been identified that can predict whether you're highly likely to respond or not as likely to respond, whether your response will be a durable response, will it be a short response, and that those exist for all cancers. Now, some patients, sometimes there's nothing that, even if you are known that your response will be short, there's not necessarily another treatment that can make your response longer. So it's something that provides you with information and knowledge, but it's not something that is necessarily actable, so that you can act upon. So MYD88, if you, as was mentioned by the other gentleman earlier, if you don't have MYD88, you're not likely to have a good response to a BTK inhibitor. That would be one reason why you may not want to have that as a first-line treatment. If you have a CXCR4 mutation, it tells us that your duration of response will be shorter. So if you want to know that, but we don't alter treatment. The treatment is not altered if we know that you have a CXCR4 mutation, because we don't have better treatments. You're getting the best treatment. So maybe that's what that physician was meaning, is that he's not going to change his management of you, and that's true at this point. We hope with time that and Dr. Treon actually mentioned this, there are drugs that are being developed that can target the CXCR4 mutation. So eventually these will be important, but they aren't right now. Okay, that was a good series of questions, and just in interest of getting through these other slides, and I might go through some of them more quickly. I assume that you are interested. Betty did mention that you wanted to hear some things about COVID and how patients with Waldenström should think about COVID, the COVID vaccination, and I did prepare some slides, so I'm happy to continue. Okay, I see some thumbs up. I don't see any thumbs down.
Let's go for it.
Yeah.
Okay. Let's see here. Let me just see what's happening. There we go. Okay, so first of all, I'm going to be talking about B-cell lymphoproliferative disorders in general, because as you can imagine, there isn't and I do have some specific data on Waldenström's, but not a lot, but there is a lot of data on, or a fair amount of data on how patients with lymphomas, B-cell lymphomas in general, respond to vaccines, and how some of the treatments that people get with lymphomas, how they affect vaccines. So I'm going to talk about that. It won't all be specific for Waldenström's, but I think it's extrapolatable to Waldenström's, especially given that we're going to be talking about some of the same drugs. And I just show this diagram here. I think, let's see, am I showing it on the right slide? Can you see my pointer?
Yep.
Yep, good. Okay. And this is just to show you that this is the pathway of a cell in the bone marrow at the left end called a committed lymphoid progenitor, and how it differentiates. It's sort of like a child, like a baby. Baby grows up to become an adult, we hope, eventually. And it's the same with this lymphoid progenitor. It goes through a series of differentiation steps, initially in the bone marrow, and eventually in lymph nodes, and it becomes a mature B cell that eventually can become a plasma cell, and the plasma cells are what make antibodies that fight infections and pathogens and viruses. And anywhere along this pathway, either in the bone marrow, which is here, or the lymph node, which is here, mutations can occur, which result in these different types of lymphoproliferative disorders. If it's a very early mutation, you can get an acute lymphoblastic leukemia. If it's something that certain mutations can affect the B cell, the more mature B cell, and cause mantle cell lymphoma, follicular lymphoma, diffuse large B cell lymphoma. Other mutations can result in myeloma, and of course, MYD88 results in Waldenström's. But these disorders share something in common, which is that they are disorders of B cells. So something has basically affected the normal B cell differentiation pathway. B cells won't behave normally in general. And what happens is that these disorders, these lymphoproliferative disorders, will progress and grow in lymph nodes and bone marrow, and they also inhibit the remaining normal B cell differentiation. So you don't get as many plasma cells, or ability, and many patients have low levels of immunoglobulins as a result of their lymphoma, whether it be Waldenstrom's or whatever, of other immunoglobulins. So you can just imagine that this is a disturbed pathway. This pathway is critical for responses to vaccines. You need B cells, you need plasma cells, you need this to be functioning optimally in order for you to generate a response to your flu vaccine or to your COVID vaccine. So you can imagine that this is not going to be, your responses are not going to be normal if you have any of these diseases. And this is an area that I'm interested in because I am starting another trial to sort of try to deal with this in CLL, chronic lymphocytic leukemia, because much of the data we have on this is from CLL, and they are the worst. They have the worst responses, those patients with CLL. And I'm going to summarize the data because there's a lot of data here, which is that patients with indolent lymphoma, Waldenstrom's, and CLL have impaired serologic responses, maybe disease or treatment related. So I've just mentioned that. The impaired responses in patients are maximal, so that patients will not have good responses within 1 year of an anti-CD20 treatment. That is known. So if you've had Rituxan or Benadmustine or something like that, anywhere from 6 months to 12 months, the most recent data says it's 12 months, you will not be able to make a good antibody response to your COVID vaccine. BTK inhibitors and BCL2 antagonists do the same thing. As long as you are on BTK inhibitors or BCL2 antagonists, your likelihood of response is low. 1 in 10 patients on those drugs will not make a good response to any vaccine that they receive, and but the effect reverses quicker after stopping those drugs than it does with the monoclonal antibodies. And then the other point is that older patients and patients with lower levels of other immunoglobulins or lower levels of immunoglobulins have lower likelihood of responses. So these are 3 important factors that predict whether you are going to respond to a COVID vaccine or not. So if you received the normal COVID vaccinations and you fit into any of these categories, you are unlikely to have a good response to COVID. So what can be done? Well, you can get a 3rd vaccine or a 4th vaccine, maybe a slightly different vaccine than you had initially. And or what I'm interested in now is a prophylactic monoclonal antibody therapy. So some antibodies have been made that basically are the antibodies you need. And it's possible to give you these, and you don't have to make the antibodies, they're already made. And these are new, they're not approved in Canada yet, and but they are approved in the US for what they call emergency use. So I'm just going to show you one example. This is data. I know that this is, you're not other scientists or hematologists, and I don't want to show too much data, but seeing is believing. So I just want to show you this, and maybe you can just sort of, this will make the point. This is for patients with CLL, and these are healthy subjects. So each one of these bars represents a different patient or a different person. And what they're measuring here is the level of antibody response to COVID-19 after vaccination. And these are the healthy volunteers. You can see that everyone here makes a response greater than 250 international units or units per mil. Every healthy volunteer, and some of them are in the thousands. And these are the CLL patients. And you can see that the CLL patients, pretty well 2/3 of these in general are not making any response. Many of them are making suboptimal responses, and only a few are making some good responses. And the response rate is 95% for healthy volunteers and down to 50% for CLL. Now, this is all comers for CLL, whether they're on treatment, off treatment, whatever treatments. And then the other very important point, I think, is that the median level of response here, as I said, was in the thousands for the healthy volunteers. You're making very high levels of antibodies. For patients with CLL, you're hardly making any antibodies in general, the median. There is a range. There are some patients who make slightly better. So these are impaired responses. This is where some of the data comes from. And then this is taken one step further, and they looked at the different treatment that these patients were having, and this is reflected here as well. If you've never had treatment for your CLL, these are the patients who have a 50% response, not a likelihood of response, not 100%, but a 50%. If you're on therapy, on any therapy, they looked at all patients on therapy, it was 20%. If you're off therapy in remission, so if you've been put in remission from your therapy, your likelihood of response, but if you're off therapy and interlapse, you're down to, again, a 25% likelihood of responding to this vaccines. And then they looked at the different therapies. So treatment naive, and the different therapies are here. These are the patients who with BTK inhibitors, less than a 20%, and anti-CD20 monoclonal antibodies. These are used for CLL, just like they're used for Waldenström. So this is pretty sobering data, but this is basically, this is the data. If you have these conditions, depending upon those parameters are met that I mentioned, you may or may not have a response. The likelihood is it's not going to be as good as a healthy volunteer, and in some situations, you may not have a good response at all. So that's one point, if you have these disorders. Now, the next point is that even if you are a healthy volunteer, so we say, this is data which has come from Israel, your response 6 months after vaccination has gone down significantly. This is a log scale. So this has gone down orders of magnitude. It's 10, it's actually, 10-fold. So it's 1/10 of what it was. This is not like a small change. This is a very significant change in your titers of antibody, even if you're healthy 6 months after the vaccine. So the vaccine, that's why we're seeing patients who are getting Omicron, or people, not patients, but healthy people who are getting Omicron, because responses are going down. And then this is based upon age group, and they go down. This is the red, so they're going down a little faster or a little more if you're over 65, and really doesn't matter if you're male or female here. So that's another point here. So even if you had a good response, it's going to go down, but if you've had a suboptimal response 6 months after that suboptimal response, it's going to be low. And then the next question is, what is oh, this is out of order. What's the third dose? If you get a third dose of vaccine, does it protect you? So this is for healthy volunteers again. So I showed you the immune responses go down. What does a third dose do? And so they basically, this was again another study in Israel. Israel's, I think, capturing all their healthcare workers or even citizens, and they're doing these, they're taking their blood at different time points, and they're getting all this data. They're very organized, I guess. And so there's a whole bunch of studies coming out of Israel, and they're good studies. They're going in very high quality journals. So that's important. So the prospective study, again, 1,928 healthy healthcare volunteers. Now, these were all offered a third vaccine at 6 months. And 278 decided they didn't want a booster. So they have freedom of choice. They were allowed not to have a booster. And they looked, the booster was given a median of 210 days from the second vaccine, about 6 months, a little bit more than 6 months. And they basically looked at infections over the next month, 39 days, pretty well. And there were infections that occurred. And there were 31 symptomatic infections, 39 total infections in a booster, non-immunized patients, and 5 in the immunized. So it didn't, and this is basically what you see, basically these are days from their booster vaccine. And if you got a booster vaccine, there's a low likelihood of you getting either symptomatic or asymptomatic infection. Whereas if you didn't get that booster, in just in that month, patients did get these infections. So what this is saying is that, yes, your titers go down, but if you get a booster, they'll go up again, and they protect you. So they are, they're not perfect protection, but they are protecting you. Then the next question was, well, does this protect against some of the variants? Do these antibodies that are being boosted, do they protect against the Omicron? So they looked at the blood in a subset of these patients, and they took the blood and they looked at, will they neutralize the wild type virus, these different variants, and Omicron. So you can see that they're not, this is blood from patients who received only 2 doses of the vaccine. So there is some protection, but it's not nearly as good as the protection against the wild type. If you got 3 doses of the vaccine and they took your blood, you can see that this has moved up. It's gone from a median of 1, a log of 1 titer, so up to a median, 10-fold greater, or even more than 10-fold, 60-fold, 64-fold better, basically. So this is a big improvement. So the point is that these titers that are being generated, even though they're better against the wild type virus, they still protect. They still have some protection against Omicron, although not as good. So again, another rationale for a vaccine. So then the question is, okay, let's look at patients with B-cell disorders, and let's look at CLL patients. And so these are patients who I mentioned. I showed you before that in general, they had impaired response depending upon whether they were on anti-CD20 or whether they were on a BTK inhibitor. It was down to 10%. So after a 3rd dose in these patients with CLL, the global response rate was 35%. 33 of 95 patients did have an improvement in their response. And if you were treatment naive, it went up to 56%. But if you were on therapy, it was only 24%. And the patients were, majority of patients were being given BTK inhibitors, and that's what we're talking about. And the response rate was, again, 1 in 4. So 25%, 28% if you're on a BTK inhibitor and you've not had a good response to your first 2, but you get a 3rd, you have basically a 25% chance of getting a better response. So it's not like getting a booster is worthless. It will help, but will it help enough is a question. So what do we know about a Waldenstrom? So this is actually, this is pretty well the last data I'm going to show you about this responses in patients with lymphoproliferative disorders. And this was actually something that was published by this gentleman here, A. Brannigan in Blood. Actually, I think this was at the ASH meeting. And actually, Stephen Treon in his talk showed you some of this data. I actually looked up the presentation, and it was this group assessed 137 patients. 91 had myeloma, and 46 had Waldenstrom, and it was a prospective assessment. And they assessed antibody levels 28 days after vaccination with either Pfizer, Moderna, or J&J vaccines. And they assessed as well neutralization and T-cell responses. And this is the summary of the data. So if you had myeloma and you got this vaccination, this booster vaccination, your response, your titer was 178, whereas was 3.98 with Waldenstrom's, was not as good. And the response rate, though, I mean, even though the response was lower, 91% of myeloma patients responded, only 56% of Waldenstrom's patients. And if you look at a spike, the antibodies to the spike greater than 250, now that's a good response. 47, half of the patients with myeloma, and only 26% of the patients with Waldenstrom's, but 26% did get a good immune response. Overall, they looked at patients over age 75, and again, this was a very important factor. If you're over age 75 and you have one of these 2 conditions, that alone is going to lower your likelihood of response. And then they looked at the individual vaccines, and it turned out that Moderna gave the best response, both in myeloma and in Waldenstrom's. It's up to 50%, 8 of 16. Pfizer wasn't as good, 14.8% response. These are high-level responses, and J&J wasn't very effective at all. Untreated patients had a higher likelihood of response. Rituximab-treated patients, 0. So if you had Ritux, this is where I'm getting that data of 0 of 12 months, 0 within 12 months. And there's other, this isn't the only one. And then BTK inhibitors, 2%, 2 of 20 patients on BTK inhibitors had a response, and then other therapies, 20%, for Waldenstrom. So again, these are sobering data. And I'm going to mention one other thing because I've mentioned it. I hope I'm only about 5 minutes left to go. And that is something I'm excited about. And because of these results, which apply to CLL, not as much myeloma, but obviously to Waldenstrom's, vaccines can help. And I definitely would not suggest that anyone not have a booster vaccine or even a fourth vaccine if you can get it. And you should be able to get it. But there are other approaches. And as I mentioned, it is possible to actually produce in the laboratory the exact monoclonal antibody that binds to the spike protein and prevents the antibody, the virus from getting in to the cell and causing illness. And that's shown here. This is the spike protein of COVID virus. It's a sort of a schematic. And this is, these are the antibodies, the two antibodies. They're binding to two different antibodies. So this antibody called Evusheld, it consists of two different antibodies which are blocking where the virus has to come to get into the cell, and that's shown here. This is, again, the virus. These are antibodies, and the virus can't get in, but bind to the ACE2 receptor. And this is, so these are, there's been a trial which has been done in patients with, it's called PREVENT, a big trial, 5,000 patients. Now, none of them had cancer actually in this. They were all patients with other high-risk diseases, depressed immune responses. They had renal transplant. They had other illnesses that suppressed their immune system. They may have had autoimmune disease and were on immune suppressants, but they randomized these patients, and there was a 77% reduction in the number of COVID cases that developed in the patients who received the antibody. So this is prophylactic. This is not, there are antibodies that are now approved in Canada for once you have the illness, but this is for before you have the illness, if you are at high risk for getting COVID and don't have a good immune response. And so there were no severe cases of COVID-19 or deaths versus 5 severe cases that were in the placebo arm. So this is an active antibody, and we are proposing to give it to patients with CLL. We hope eventually, CLL patients who have been shown not to have good immune response, we're hoping eventually we can extend this to other lymphoproliferative disorders. So there is a consensus statement that has been produced, and some of the people on this guideline recommendations, Jorge Castillo, who's also from the Dana-Farber, and Stephen Trion. And they looked at, well, how should physicians and doctors manage patients with Waldenstrom's during this pandemic? So should we be changing the indications for therapy in Waldenstrom's macroglobulinemia? And so what they suggest is do everything you can to avoid starting patients on treatment. So if a patient needs treatment, they must start, but maybe if you're starting when their hemoglobin is 90, you wait till it's 85. Maybe you should try things like iron or erythropoietin to see if you can keep the hemoglobin up, if that's the indication for treatment. Should we change our approach to initial therapy? Oral therapies might have certain advantages. This is not practical. This is not possible in Canada because we don't have first-line oral therapies. We do have first-line, second therapies. Minimize maintenance therapy. So the problem with maintenance therapy is that there's never been shown to be a survival advantage, and it does require visits to the cancer center every 3 months. Maybe these should be avoided during a pandemic. Should we change therapies for non-COVID-19 patients who have already started treatments? And should we stop BTK inhibitors? Well, they say no, because these are important therapies. Patients need it. And there is some evidence that actually BTK inhibitors reduce the pulmonary severity in animal models. And so it may be that they could be helpful, but there's no indication to stop them. If a patient needs treatment, don't. But if you are a patient getting chemoimmunotherapy, maybe you would want to do fewer courses than longer courses. This is a discussion that you have to have between the doctor and the patient, because if you have fewer courses of therapy, your remission may not last as long. Try to minimize visits, use telemedicine, longer prescription refills, oral treatments. Should we change our approach to supportive care? Keep people out of hospital. So that could involve using GCSF as a patient is on treatment, but I think patients are already getting GCSF if they need it. IG replacements, immunoglobulin replacements, if their immunoglobulin levels are low and they're at risk for infections, this might reduce the number of infections. Autologous stem cell transplant is definitely something that we don't usually do in Waldenstrom's, but we are trying to avoid autologous stem cell transplants except for where there's a critical need. Now, for example, myeloma patients do need autologous stem cell transplants on time because they will live several years longer if they get these. So that is not a recommendation for that population. And what about patients enrolled in clinical trials? Well, this has to be discussed with trial coordinators. So IRBs at Sunnybrook, for example, have provided guidelines and have actually stopped some clinical trials. Clinical trials where there's not an important need for treatment for patients in general. So monitoring trials, trials where it's not going to have an impact on the longevity of the patient. Our trial was reviewed and was felt that this was an important trial to continue. But this is again something that is being done at every cancer center, to make sure that that this trial is something that is needed, is necessary at this time. And then a few other things that I don't have to really go through. The question is, what if a patient on a BTK inhibitor gets COVID? Should you stop the BTK inhibitor? And it's a difficult question. It depends on how severe the COVID is, what the oxygenation status is, what the imaging looks like, what the patient's status of their Waldenstrom is, because if you stop your BTK inhibitor, your Waldenstroms may flare. And so we don't want that. Could the BTK inhibitor inhibit the immune response and delay the clearing of the COVID? That's something that has to be looked at in an individual basis, basically. Some patients are getting asymptomatic infections and don't have chest x-ray changes and don't have low oxygen saturations, and those patients, I wouldn't want to stop the BTK inhibitor, but if they're in the ICU and requiring oxygen, yes, we probably should stop the BTK inhibitor. So, and then just about the use of vaccines. These two slides just say, yes, you should get a third vaccine and you should get a fourth vaccine. And that's what NACI, National Advisory Committee on Immunization, they describe patients with high risk immunosuppressed patients. So that includes patients with on active treatment for solid tumors or hematologic malignancies. All patients with Waldenstrom's fall into this category. That means that everyone is eligible for a booster vaccine or a third vaccine and a fourth vaccine. Third vaccine at 6 months after your second vaccine, and a booster vaccine at 3 months after your third vaccine. So, so I'm going to stop there and show you this last slide. Talks about BRAWM, map of Canada. We go from sea to sea, and we're very proud of that. And we're hoping that we will benefit Waldenstrom's patients with this trial across Canada. So any other, I'm happy to take any questions on the last section or any section. So please feel free.
Ray, you need to put your mic on.
Sorry, Dr. Berinstein. Someone, WM patient sent me a question, if I may ask you, and there's a few in the chat. This is a person from Calgary who had 2 Pfizer vaccines before he began treatment with Benadmustine Rituximab over the summer. And he had his Pfizer booster shot in November after he completed his chemo. And of course, when he did the test, he has no antibodies, and his hematologist told him that the Benadmustine Rituximab probably wiped out all his antibodies. So the question is, can he, for his emotional well-being, redo the vaccines at any time soon? Like what would you do in a case like that?
Yeah.
If you had 2 vaccines and a booster.
Yeah, so I think he should redo the vaccines, but again, he probably should wait for 12 months.
Okay.
I've actually made the mistake of having some patients, of using the 6-month number, and some patients just haven't. At first, I thought that actually there's data with flu virus, the annual flu virus, that actually after 6 months you do get responses with after 6 months of treatment. If you hold off for 6 months with Rituxan and then you get your vaccine, that you do get flu vaccine, but it doesn't seem to be the same with COVID. And so I think that I would definitely wait for 12 if he wants to get the most value. It's all a balancing act here. Now, the situation is changing. If we had a situation where we had a very, very deadly virus now, you might want to rush that from 12 months, but I'm not sure you're doing yourself any benefit. We have a mild virus now that's causing mainly, mild symptoms. I think I would isolate. I'd be not isolate, but I'd be very careful. I'd wear a mask. I would try to get, I wouldn't go to Costco. And at 12 months, I would try to get revaccination. I would try to get several. I think that you could redo the entire vaccination, series. Yeah.
Okay. All right. And according to what you said, one of the questions said, if you've had 3 Pfizer vaccine, would you recommend, if you can, to get Moderna as your 4th, since it has a better?
Yeah, I think the 3rd and 4th vaccine, if you've had 2 Pfizers or 3 Pfizers, I would go for Moderna. I think Moderna, what I'm seeing is that Moderna is a more potent vaccine. So I would try to get Moderna. Okay.
And someone else wrote, they got COVID despite getting 3 doses, but their symptoms were very, very mild. It's probably the antibodies he probably had protected him. Would that be correct? Okay.
Yeah, I think there's 2 factors there. I mean, you look at Canada, we're 85% immunized, and the levels are going down if you haven't had your 3rd vaccine. So that explains why some people are getting COVID. But I think that there's some basal level that's protecting and making the illness milder in Canada and other parts of the world. And so I think that that's very important. And there's also, we look at antibodies, we measure antibody responses. We don't really have a good handle on what's happening to T cell responses. We know that there are T cell responses. We know the vaccines generate them. We don't know what level is necessary to protect against diseases. But so yes, I would say that he had mild illness because he's been vaccinated previously. Patients on treatment do get sometimes more severe illness. So the fact that he's had, or even patients with these immune suppressed illnesses, lymphoproliferative disorders, may get more severe. The fact that he's had milder makes me think he's had some level of protection.
And someone was asking if the WM makes us more susceptible to get shingles also.
I think that probably a little bit more susceptible. It's not like it's an epidemic, but it's yes, we see a fair amount of that in patients with on treatments for different lymphoproliferative disorders. We do recommend vaccination, but again, not within 12 months of a Rituxan-based treatment.
And back to the 4th dose, how long do you suggest between the 3rd and the 4th vaccine?
Well, I have one slide that shows that, and Nancy says basically they said 4th dose of vaccine should be at least 3 months from the previous vaccine. Now, there is also data that if you wait a little longer, you go up to 6 months, you might get a better response.
Okay.
Yeah.
Okay. Is there anyone who has a question that they might not put in the chat that would like to ask Dr. Berinstein?
I want to follow up on the question that was asked about the chap here in Calgary. How he's having difficulty finding how he can get a redo on his vaccine. How do you go about that?
It's my understanding that centers are getting more liberal, and I think sometimes a note from the hematologist could be helpful. I mean, he is entitled to a 3rd and 4th vaccine, so that should be done. But I think that with a note from his hematologist that he's shown to only have they have shown to not have any immune response, and that he's now waited 12 months from his immune suppressive treatment, and that he needs a vaccination, in a closer interval. I think he should be. The problem if he tries to get the third and fourth vaccine is they'll make him wait a long interval. Really what he wants is 2 priming doses 3 or 4 weeks apart. And so I think he needs to get a letter from his hematologist, and I'm sure that places that would help him.
Okay, is that the end of the questions, Ray?
I think so. The other ones were not COVID related, and we might be running short on time.
Okay, well, thank you so much, Dr. Berinstein. I found that very helpful. And I'm sure if people have additional questions, can they email you privately?
Or email us to.
Yeah, they can email. Sure, we probably have my
Okay.
email there. And I want to. It's difficult for me to deal with individual medical questions. I really shouldn't do that because I'm not your physician, and
Yeah.
you do have
that they need to be general for sure.
Yeah, they have to be general. So I'm happy with general because I don't want to say things that are. I think you have to go to your hematologist and address these questions with your hematologist. But I'm happy to answer general questions.
May I ask a general question? Last one.
Yeah, this will be the last shot.
I'm sorry. I am a WM patient. I finished my treatments back in October. Relatively recently, my wife contracted COVID. And so we isolated on all the rest of that stuff. But now that she has had it, is she at less risk to transmit to me?
And the 3 vaccines.
And she had 3 and I've had 3
Vaccines.
I would say yes, because see, one of the problems that we have is that the vaccines we have now actually need to be changed. They need to be improved. The vaccines we have are specific for the Wuhan variant. There's all sorts of mutations and changes in these viruses that are circulating now. So these vaccines, and I'm surprised that Pfizer and other companies haven't come up already with a better, more specific vaccine. But if she had the virus, that's the best, if assuming she had Omicron, which she likely did nowadays, she's probably generated a very good immune response. She's cleared it. She's well, I take it. She's asymptomatic.
Yeah.
She should have the best of all of us immune response to Omicron, which is the virus we're most concerned about. Now, there may be other viruses coming down, which our immunity to Omicron doesn't help. But so yes, I would say she should be very highly. She's unlikely to transmit it to you.
Thank
Okay,
you.
thank you again, Dr. Berinstein. I think we'll end our question period right now. We do have, and I'll stop the recording.